Very good. How many sessions of neurology did you have with me? Everyone, please answer. None. Okay. Anyone had any neurology sessions with me before? One. Okay. Let's just start. Here's the first question. A woman comes to emergency department with severe headache starting 1 day prior to admission. On physical examination, she has a temperature of 39.4, local rigidity, and photophobia. Her head CT is normal. LP shows CSF with 1250 white BCs and 50,000 red blood cells. What is the most appropriate next step in the management? Angio, ceftriaxone, and vancomycin, nimodipine, embolization, surgical clipping, and neurosurgical consult. What is the most probable diagnosis? Meningitis. Why it is not subarachnoid hemorrhage? The patient has a severe sudden headache with neck stiffness, and there are many RBCs in the CSF. Why it is not subarachnoid hemorrhage? Yes. Photophobia you may have, but fever, no. Yes. The subarachnoid hemorrhage cannot cover the fever for you. And the CT scan is normal. Although CT scan being normal does not completely rule out subarachnoid hemorrhage, but still it's a big point against subarachnoid hemorrhage. So yes. In these patients, when you have a clinical diagnosis of meningitis or meningoencephalitis, even if you don't have the LP results or the culture results, you will start antibiotic. It's a febrile emergency. Febrile emergency means you have to start the treatment right away, even if you haven't done the LP yet. In this case, you already done the LP, so good. Send the LP result for gram staining, microscopy, and culture. And then later you can tailor your antibiotic regimen based on the results, but do not wait for the results. Antibiotics should be started immediately. All are associated with Wernicke's encephalopathy except cogwheel rigidity, alteration in mental function, sixth nerve palsy, and ataxia. Very good, very good, very good. Yes. What is Wernicke's encephalopathy? Anyone can tell me? Yes, very good. Many people, they say Wernicke's encephalopathy is a long-term, is a complication of alcohol intoxication, but it's not actually. Actually, it's a long-term form, chronic form of thiamine deficiency. By a thiamine deficiency, which could be caused by alcohol intake for a long time. It could also be caused by nutritional deficiency, absorption problems, anything that could cause thiamine or vitamin B1 deficiency. There's a triad, it's a classic triad. Anyone knows the triad? Yes. Yes, exactly. You can see the triad there. B, C, and D. Confusion, ataxia, and ophthalmoplegia, which can be seen as an nystagmus or the sixth nerve palsy. But it's not common. You don't see all at once together in all the patients. It's not that common to see all three at the same time together. There are some other stuff too. The diagnosis is clinical, and you give the patient thiamine. Your patient might have um, hypoglycemia too at the same time due to alcohol intoxication. But please give thiamine always. Give thiamine before you give glucose. Clear? Yes? Very good. Okay, now cogwheel rigidity. Where do you see the cogwheel rigidity? Yes, most commonly Parkinson's. Anything else? Drug side effects. Don't forget antipsychotics, drug side effects, other forms of dementia like Lewy body dementia also can cause cogwheel rigidity, but most commonly you will see it in Parkinson's. Patient came with ischemic stroke after 6 hours. What is the treatment? Aspirin, TPA, clopidogrel, heparin, other anticoagulants. A, B, A, okay. Let's go step by step. Give me some signs and symptoms of ischemic stroke, or generally any stroke. Which signs and symptoms the patient comes with, do you think, okay, this is a stroke, or this may be a stroke? Weakness, dysarthria, correct? Yes, fast, it's called be fast. Balance problem, eye problem. Very good. So when a patient comes with signs and symptoms of a stroke, what is the first thing you do? Patient comes with signs and symptoms of stroke. What is the first thing you do? First, check the time of the onset. Good. Anything else? When a patient comes to you with a stroke, the first thing is to clear out whether it's an ischemic hemorrhage, it's an ischemic stroke, or it's a hemorrhagic stroke. The management is completely different. The management are the exact opposite. In one of them, you have to anticoagulate. In the other one, you have to stop any anticoagulation that might be going on. So the first thing is to whether see what is going on in the brain. Is it ischemic or is it hemorrhagic? So how do we clear that out? What type of a CT? Non-contrast CT, plain brain CT scan. In the plain brain CT scan, there are three scenarios. One, you see the hemorrhage. Two, you see the ischemic changes. Three, you see nothing, it's normal. Tell me what you do in each of these scenarios. One, you see the hemorrhage. What do you do? We're not talking, of course, about traumatic brain hemorrhages. We're talking about stroke. It's a hemorrhage. There is no clot. It's a hemorrhage.
If patient is on any anticoagulants, we should stop that. We should maintain the BP so that it further bleeding doesn't occur. And
Yes. Technically, you should do just supportive management. If it's any anticoagulation going on, stop it. If the blood pressure is high, maintain it in the normal range. And refer the patient to the neurosurgical or neurological team. Done. Second scenario, you will see ischemic changes. What do you do?
we have to see the time of onset. If it is within the golden hour, 3 to 4.4.5 hours. If it is between that, we can thrombolize the patient. If not, we should not. And if it is within 120 minutes, we can consider doing PCI also. If not, we should give supportive medical management.
Okay. PCI is for the heart. So,
Also, yes.
yeah. Okay. We have interventional neurological processes that you can go on like like just go inside and get the clot exactly like what you do in like similar of what you do in PCI, you can do also for the brain. But the time frame is not 20 minutes or like that. Yes, if you see the ischemic changes, you look at the time frame from the onset of the symptoms, not from the patient's arrival, from the definite onset of the symptoms. In this scenario, if the patient tells you, I woke up with the symptoms, that is not considered the definite onset of the symptoms, so you cannot give the patient thrombolytics. But if it is within 3 hours of the onset of the symptoms, you can give thrombolytics, of course, if there is no contraindication. Between 3 and 4.5 hours, you can decide based on the patient. It's giving the patient thrombolytics is controversial in that time frame. So you have to decide whether you want to give the patient thrombolytics or no, based on the patient, the chance of hemorrhage, the chance of having a massive stroke. You have to decide. After 4 hours, after 4.5 hours, there is no thrombolytics. You just have to give the patient aspirin, symptomatic management, and hand over the patient to the neurologist. Third scenario, which is technically the most common scenario, is that the CT scan is normal. Then what do you do?
Normal stroke does not rule out ischemia. So, so maybe we'll continue with the medical management and repeat CT.
So here's the thing. Yeah, the ischemic changes sometimes takes time to show themselves in the CT scan. So if the CT scan is normal, it doesn't mean it's not an ischemic hemorrhage, okay? It's not a, I'm sorry, it's not a hemorrhagic stroke. So what you have to do is do the same thing, exactly the same things as the ischemic stroke. That is why when we are describing the CT scan results, we say hemorrhagic stroke and non-hemorrhagic CT scan. We don't say ischemic CT scan because you may not see that in the first 48 hours. So we say if it's hemorrhagic, do the hemorrhagic management. If it's non-hemorrhagic, do the ischemic management. Got it?
Yes, ma'am.
Very good. Seventy-year-old man with extremely severe Parkinsonism comes by ambulance to the emergency department, secondary to psychosis and confusion developing at home. He's maintained on levodopa, carbidopa, ropinirole, and tolcapone. What is the most appropriate next step in the management? Stop levodopa, start clozapine, stop ropinirole, stop tolcapone, start haloperidol. Okay. Anyone has any idea? Okay. Let's talk about psychosis in Parkinsonism. In Parkinsonism, you can have psychosis, but usually psychosis in Parkinsonism comes very late in the disease. You know, the primary signs and symptoms in Parkinsonism is the motor signs and symptoms. The rest of the symptoms, the cognition and these forms of symptoms like psychosis, they come late. Many times in Parkinsonism, the psychosis can come from the drug side effects. Many of these drugs for Parkinsonism, they work with the dopaminergic system and they can cause psychosis. So what to do if a patient comes with Parkinsonism? What medication to give, what medication to stop, like that. Number one, if to see what was the problem. How did this psychosis start? First thing first, make sure nothing else is going on. Example, you know, people can have psychosis in delirium. okay? So make sure it's not a delirium, especially because your patient is confused, okay? Make sure it's not meningitis. Make sure it's not any other infection or any other severe medical or surgical situation that could cause psychosis, because in that case, it means you have to treat the psychosis and you also have to treat the underlying cause. Do you understand?
Yes, ma'am.
Right. Second thing is that to review the patient's medication to see if patient recently started any medication that could cause this form of psychosis. Okay. Example, this ropeneol that could cause psychosis, probably not the confusion, but it could cause psychosis. It's not that you jump and stop the patient's medication, not like that, but you can review the patient's medication. The important thing is that levodopa should be the one that you suspect the least. It's the least psychogenic, and you have to keep it as long as possible. Is it clear?
Yes, ma'am.
Very good. But for the psychosis treatment, you have to be very careful, because antipsychotic medications, they also work with the dopaminergic system. You know, they are dopamine antagonists, okay? So you give them, the psychosis gets better, but the motor system might get worse, and you know that, especially the first generation antipsychotics, they have severe motor side effects. You know that, right?
Yes, ma'am.
Right? Yeah. The first generation, the typical antipsychotics like haloperidol, they have prominent motor side effects, extrapyramidal. That's why always we give haloperidol with biperidine to control the motor side effects. So as of this, you know that even if you want to give the patient antipsychotics, you have to avoid first generation, avoid typical antipsychotics. Try to start with atypical or second generation antipsychotics. In the antipsychotics, one of the best thing you can use is clozapine. Clozapine is very strong. It works very good in these cases, and the motor side effects are minimal. So what is the correct answer for now?
Option B, ma'am.
Very good. Yes, you start clozapine for this patient. Another acceptable
So
option.
continue clozapine along with levodopa, ma'am. I mean, rest of the drugs.
The patient's medication. Let continue. Just
Yes, ma'am.
add the patient for now for the psychosis. Add the patient, add clozapine for the patient, and then see what is the cause, what is going on.
Yes, ma'am.
Okay, but the choice is not clozapine. The choice is another medicine that is not in the options. You have two other options too. One of them is an acceptable option. One of them is the best thing. The best thing you can give the patient is an antipsychotics called pimavanserin. That is the choice, but it's super expensive. And it's not available. Most of the places it's not available. So the next best would be clozapine, which is available everywhere and it's not expensive. Also, quetiapine is an acceptable option. But in these options, of course, it's clozapine. The drug of choice for absence seizure: valproate, gabapentin, carbamazepine, phenytoin. Yeah, very good. So here's the thing. For literally every form of seizure, if you don't know what to say sodium valproate. So here, as you can see, in every form of seizure, partial seizure, first-line medication, sodium valproate. Tonic-clonic, sodium valproate. Myoclonic, sodium valproate. Absent, sodium valproate. Atonic, sodium valproate. So as you can see, sodium valproate is always on the first line. So that's a very good safe choice. Woman comes to the emergency department with bilateral leg weakness developing over the last few days. She has lost her knee jerk and ankle reflexes. The weakness started in her feet and progressed up to her calves and then her thighs. She is otherwise asymptomatic. Which of the following is the most urgent step? Pulmonary function test, arterial blood gas, nerve conduction study, lumbar puncture, and peak flow meter. What is the diagnosis? What is the diagnosis? No. Myasthenia starts up, down, not down, up. Myasthenia starts from the eye. And it's not progressive, it's fluctuating. Myasthenia in the morning is fine, in the evening gets worse. Again, in the morning it's fine, in the evening gets worse because of repeated use, overuse. Of course, if your patient has night shift, it's better in the night, it's worse in the morning. But generally, after overall use, myasthenia gets worse, and again, it starts from the eyes. But this is an ascending. It started down, coming up. Yes, it's Guillain-Barré. Most probably it's Guillain-Barré syndrome. What kills the patient in Guillain-Barré? You know, Guillain-Barré is most of the times a self-limiting disease. It usually gets better spontaneously with minimal complications. But what kills the patient in Guillain-Barré? Yeah, what kills the patient in Guillain is respiratory failure. So for that, what you should do?
Pulmonary function test.
Yes, you have to do pulmonary function test to see if the patient has any restrictions or no. Because if the patient has any restriction, it means it's coming up. You have to keep the patient, you have to put the patient on the ventilator and do the supportive management until it clears out, usually weeks later. Correct. Investigation of multiple sclerosis includes all except visual evoked potential, lumbar puncture, MRI, and CT. Anyone? We have 2Ds. No, lumbar puncture is there actually. Yeah, the first, of course, the first one is MRI, either brain MRI or brain and spine MRI based on the patient's symptom. If you saw the classic signs and classic view, what is the classic view? What do you see in the MRI of patients with multiple sclerosis? Yes, you see plaques. You see plaques. Most typically periventricular plaques. You see plaques around the brain ventricles. Yes, if you saw them, then fine. If you didn't see them, the next step would be LP and evoked potential tests. But CT scan nowhere. EEG is usually abnormal in all of the following except subacute sclerosing panencephalitis, locked-in state, Creutzfeldt-Jakob disease, hepatic encephalopathy. We have 1B. Anyone else? Yeah, and all of them, EEG is abnormal except in locked in. Locked in state, usually EEG shows nothing. Technically, doesn't matter how much you look for an abnormality, there is no abnormality. What is subacute sclerosing panencephalitis? Anyone knows?
It's a complication of measles infection.
Yes. It's a complication of measles, but the problem is that it's a very, very, very late complication of measles. That is why it usually gets overlooked. It could come after 20 years of a measles infection. And yes, usually the patient doesn't survive it. Creutzfeldt-Jakob disease comes from prions. You may heard of the mad cow disease. It's a form of that. It could be genetic, hereditary, or sporadic by eating the protein of the cows who have the same problem. And hepatic encephalopathy, everyone knows what is that. All of them, you have abnormal EEGs. 40-year-old male with history of daily alcohol consumption for 7 years is brought to the hospital emergency room with acute onset of seeing snakes all around him in the room, not recognizing family members, violent behavior, and tremulousness for a few hours only. There is history of him having missed the alcohol drink for 2 days. Examination reveals increased blood pressure, tremor, increased psychomotor activity, fearful affect, hallucinatory behavior, disorientation, impaired judgment, and insight. He's most likely to be suffering from A, alcoholic hallucination, delirium tremens, Wernicke's encephalopathy, and Korsakoff psychosis. Very good. What is the difference between delirium tremens and Wernicke's encephalopathy in terms of using the alcohol?
Delirium tremens is due to withdrawal of alcohol, whereas Wernicke's is due to thiamine deficiency.
Very good, yes. One comes from long-term use of alcohol that caused vitamin B1 deficiency, so it comes from using the alcohol. The other one comes from long-term of alcohol that now has suddenly stopped. So other one is from alcohol withdrawal. "66-year-old woman." Oh, this is not a good question, sorry. This is better. 32-year-old woman complains that her right leg has become progressively stiff and clumsy over the last couple of weeks. She's worried as she has not been able to go to work for the last 4 days. On examination, tone is increased and there is a catch at the knee. She has 6 beats of clonus and an upgoing plantar. Power is reduced 3 to 4 out of 5 in the right leg flexors. There is no sensory involvement and the rest of the neurological examination is normal other than a pale disc on ophthalmoscopy. On further questioning, she admits that she had 2 episodes of blurred vision in her right eye in the last 2 years. Each lasted a couple of weeks, from which she fully recovered. What is the most appropriate initial treatment? NSAID, interferon beta, bed rest, methotrexate, a course of oral steroids. What is the probable diagnosis?
Multiple sclerosis, ma'am.
Uh-huh. What is that eye symptom that the patient has?
Optic neuritis.
Yep. Of course, in optic neuritis, you should have a little pain too. But yes. Yes, multiple sclerosis. Patient is in a flare now. What do you do?
Steroids.
Yep. Very good. Well, thank you, everyone. That was your
Previously, you
neurology.
showed the question, patient suffered from RTA.
From RTA?
That cranial nerves question, ma'am. Actually, I have a doubt in that.
Yes, that's why. Let's go to that question too. This one, yeah.
Yes, ma'am, because in our textbook, this question is given 2 times, and in one, the answer is facial, and the other, the answer is trigeminal.
Mm-hmm. What do you think?
Facial, ma'am.
Yeah, I think that too.
Okay,
Because
thank you.
it's working with facial expressions, right?
Yes, ma'am.
Okay. Actually, this question, there's a problem in this question in the sense of the tongue, anterior 2/3 of the tongue. It didn't specify which sense, okay? Because the 2/3 anterior sensation of the tongue, it might get mixed with the nerve 5, right? But it's obviously saying that it's the deviation angle of the mouth, right?
Yes, ma'am.
Actually, the anterior 2/3 of the tongue, the general sensation, not the taste. The general sensation comes from nerve
Trigeminal.
5, right?
Yes,
Comes from
ma'am.
the trigeminal. But the deviation of the angle of the mouth is obviously number 7, okay? As you have that, and also number 7 has some parts in the tongue too.
Special
I
sense.
would go with number 7. But I know that you have this question 2 times and one is 7. I think there's a problem in the base of the question. This question should be changed. That's why I skipped this question. This question should be changed because it actually referring to 2 nerves. But in this question, I would choose number 7.
Okay, ma'am. Thank you, ma'am.
Yeah. So have a good day.
Thank you, ma'am.
You're welcome. Have a good day.